Welcome to Session 5, Core Curriculum, Cranial Nerves, Anatomy and Workup of Related Symptoms. Our first speaker is Dr. Justin Brucker, Assistant Professor of Neuroradiology at the University of Wisconsin School of Medicine and Public Health, Madison, Wisconsin. His topic for today is anosmia.
Thank you for tuning in to this session on cranial nerves. I'm thrilled to be kicking off the session with a talk on olfaction and olfactory disorders. Very special thank you to Dr. Schmalfuss and the ASHNR committee for putting together this meeting and for the opportunity to speak on this great topic. I have no disclosures. I should point out I am not an olfactory scientist, but I do find this topic very fascinating. Olfaction is a bit of a paradox. It is one of the oldest and most highly conserved sensory systems in the animal kingdom, important for all aspects of survival, although we do find it integrated in most complex, evolved human behaviors through the provision of chemical cues about our natural and cultural environment. And in addition to being a massive industry, olfaction has significant implications for a wide range of medical conditions. Certain jobs are contingent upon intact olfaction, and a loss or disrupted sense of smell can really impact quality of life and personal safety in a negative way. What are smells? These odorants that bind olfactory receptors can actually trigger different kind of olfactory characteristics through different aspects of their composition, but it's really kind of interesting. It's hard to predict kind of how something's going to smell. You can have two completely different molecules that have the same smell, or two very similar molecules that have completely different odor profiles. You could have, in the case of stereoisomers, these chemically identical, albeit mirror image molecules that'll register as different scents. In the case of carvones, right-left carvones smell like mint and caraway, respectively. So something very interesting and kind of complicated is going on. There's a lot of controversy about kind of how this is actually mediated, but what we do know is that the olfactory receptor is a G protein coupled receptor that stimulates adenocyclase, ramps up cyclic AMP, and essentially drives action potential formation. We do also know that these receptors are encoded by the largest gene family in vertebrates, although only a small percentage of these genes are actually functional. That being said, we're somehow able to discriminate a large range of different odorants, which does confirm that there's something more than just a one-to-one ligand to receptor relationship going on. This is more nuanced than we need to know for radiology, so I'm just going to break it down to three main steps: conduction, signal transduction, and central processing. And conduction is really just nasal airflow. We're trying to conduct the odorants to the olfactory epithelium. We also need to be able to humidify and warm the inspired air. And also, the odorants need to diffuse into the olfactory mucus and bind to odorant binding proteins. And then the epithelium has to also be intact and normal. That epithelium is comprised of primary olfactory sensory neurons as well as supporting cells. And on these apical surfaces of these neurons are these ciliary projections that express one type of olfactory receptor. And those signals are transduced to the glomeruli within the olfactory bulbs, which are also receptor specific. And then those action potentials are sent to the olfactory cortex. And olfactory cortex, where the central processing occurs, is broken up generally into the medial and lateral pathways. Medially, you have kind of integration with limbic and autonomic areas, and laterally, you have integration with kind of the memory and kind of emotional centers of the brain. And there are other kind of more associative pathways involved in humans. When you're approaching someone who has an olfactory complaint, you got to really look at their whole health, because there's a lot of various neurocognitive, neuropsychiatric, and systemic conditions that can affect olfaction. In 2020, we had to be very mindful that COVID-19 is associated with anosmia. Also, a lot of common medications and environmental exposures are also associated with olfactory disorders. So a very comprehensive history has to be taken in these patients before we do any sort of formal workup. And also we should be asking specifically about intracranial symptoms, other cranial neuropathies, and signs of pituitary dysfunction. There's a lot of nuance in the terminology describing dysosmias or some sort of undesired alteration of olfaction. You can have the troposmias, which include things like parosmia, which is distortion of an odor perception. Cacosmia is just a very unpleasant version of that. Phantosmia is perceiving an odor without an actual odorant presentation, which can be a sign of more CNS pathology. And of course, reduction in olfaction can be seen in various conditions, including normal aging or neurocognitive diseases. There's also a tactile quality or textual quality to olfaction, which is mediated by the trigeminal nerve via these TRP receptors, and this kind of adds the cool, hot, spicy, pungent qualities to some molecules. So if you've ever like had smelling salts or wasabi in your nose, you kind of know what I'm talking about. And also, some patients who complain of altered smell are actually complaining of impaired taste or dysgeusia, which is also mediated by different cranial nerves. In addition to this comprehensive clinical questioning, we have to consider setting patients up with more formalized testing, and most of this is usually achieved through some sort of kind of controlled odor and presentation, and seeing if they can either identify and name what the unknown odorant stimulus is. But a lot of these patients also go on to getting imaging, and I just point out that imaging studies are most effective when we've already performed clinical characterization of their olfactory disorder. Our goals are to, of course, identify a lesion along the olfactory pathway, but also in patients who don't have a lesion, to look for other clues of there being a systemic or neurodegenerative illness that may cause their complaint. The CT and other strategies are complementary in a lot of cases, but once you kind of have that full clinical history, you can maybe recommend like a CT for like a conductive dysosmia, or if you suspect something that's more directly affecting the olfactory organ, you may want to consider getting like a dedicated MRI. And patients with suspected CNS or systemic diseases, they may be better off getting just a more comprehensive MRI of the head. A lot of people have their own kind of go-to sinonasal MR protocol. Here's kind of what I like to use for these types of indications: high-resolution T2-weighted isometric imaging of the olfactory bulbs and tracts, 3-planar high-resolution 2D pre-contrast T1 imaging of the sinusoidal cavity. You want to make sure you include the pharynx. T2-weighted imaging in the same planes, but with like really uniform fat suppression, either through stir or some sort of Dixon-type fat water decomposition. And certainly uniform fat suppression on your post-contrast T1 images. And diffusion can be helpful for detecting purulent or hypercellular lesions as well. There's also kind of this controversy, like, should we even do MRIs? Is it cost effective? There are studies out there that have shown that the MRI workup versus the non-MRI workup have very similar efficacy, although with a huge difference in cost differential, suggesting that no MRI is potentially the more practical way to go. In my own kind of review of cases, I can attest that there aren't a lot of times when you'll find a obvious olfactory tract lesion on MRI. A lot of these things can actually be determined through kind of clinical interrogation in CT. But that being said, there are some medical, legal, and just sort of biopsychosocial considerations with anosmias. Misdiagnoses can have significant medical, legal costs, and also just an untreated or misdiagnosis can lead to significant reductions in quality of life, employment, and personal safety. So for conductive dysosmias, we're essentially just talking about impaired airflow. This can be antegrade orthonasal or retrograde retronasal, or diffuse. There can be clues in the clinical history, such as like persistent laterality or testing with nostril occlusion, that will confirm that this is most likely a conductive anosmia. But also ask about other signs that could suggest localization to the sinonasal cavity. And endoscopy should be performed ahead of time, and CT can be very helpful as well. So with retronasal airflow, the flow tends to be more turbulent and slower. This facilitates taste because odorants are being carried from the back of the mouth, and therefore can also be associated with dysgeusia, and parosmias and phantosmias can also occur with this pathway. Here's an example of someone with altered taste and reduced sense of smell due to an obstructing lesion of the retronasal conductive pathway with this inverting papilloma. And here's someone who had a parosmia due to purulent material within the sphenoid sinus, and that material was wafting into the sphenoethmoidal recess and being picked up by the olfactory epithelium. Now, orthonasal flow tends to be more laminar and faster than a retronasal flow, and it's kind of what we typically think of when we're talking about conductive anosmias. Only a small percentage of the odorants that are inhaled actually make it to the olfactory epithelium, but sniffing can accentuate this process by increasing speed and turbulence. And so when we're assessing the kind of the functional kind of airflow within the nose, we should be looking at several important sites, like internal nasal valves, which are kind of right along the anterior margin of the inferior turbinate, and these extend back into the olfactory recesses or clefts, which are on the dorsal margins of the perimedian nasal cavity, marginated by the septum and the turbinates. And these go right to the cribriform plate. So you have olfactory epithelium here with the sensory neurons, and those will project to the olfactory bulbs within the fossae. And obviously, anything that's going to alter the anatomy and airflow is going to lead to a conductive anosmia. And so here's an example of someone with rhinoplasty who was complaining of nasal congestion and decreased sense of smell. And we can see there's some distortion and narrowing of the internal nasal valves with apposition of mucosal surfaces. Here's another patient with a very similar configuration, but this case caused by a vasculitis, causing remodeling and saddle nose deformity of the nasal bridge. And here you have blunting and obstruction of the internal nasal valve. And this is an example of how the history of ipsilateral, consistent, lateralized congestion and conductive anosmia can help us confirm that there is an obstructive lesion in that conductive pathway. In this case, it was a pyogenic granuloma. And olfactory clefts themselves can also be stenotic or occluded, in this case by a large concha bullosa, causing narrowing and mucosal apposition, therefore blocking conduction of odorants. Diffuse global types of conductive blocks can be seen with any sort of chronic sinonasal inflammatory condition. Here's an example of Santor's triad, which is asthma, sinonasal inflammation, polyposis, and aspirin sensitivity. You can see just that there is no air getting through the central nasal cavity, and the olfactory clefts are completely occluded. This is an example of Kartagener Syndrome. It's a chemociliopathy, so you have impaired mucociliary clearance, which leads to chronic sinonasal inflammatory changes. And in this patient who has hyposmia, there's also the classic dextrocardia and varicose bronchiectasis. Transductive or peripheral sensorineural dysosmias are a little harder to localized clinically because there can be some overlap with both conductive and central olfactory disorders, and they can have both reduced olfaction as well as distorted olfaction. Also, this is kind of where presbyosmia occurs because as we age, we have changes to our olfactory epithelium. It starts to convert to normal respiratory epithelium. We have decreased olfactory sensory nerve renewal and receptor expression. And in cases of parosmia or phantosmia, sometimes they can respond to neuroleptics or anticonvulsant medications. But a lot of these cases actually may not have an imaging correlate and are probably either idiopathic or associated with viral infections. Brings me to the most famous viral infection causing anosmia right now, which is COVID. We know there's a high association of anosmia early in these infections, which can persist in some patients. It has been described as being partially mediated by binding of the virus to the ACE2 receptor, which is highly expressed in the olfactory epithelium, but not to the olfactory sensory nerves themselves, suggesting that maybe there's some kind of collateral damage that may not be permanent. However, some patients have also reported other aspects of altered taste and chemesthesis in the nose, and also some reports have suggested there could be direct olfactory sensory nerve involvement. Although some of the early case reports didn't show any observable changes in MRI within the olfactory bulbs and tracts, there are some anecdotal reports that I know of people suggesting enhancement and abnormal signal within olfactory bulbs, and there are a couple of case reports in the literature too that confirm this that I encourage you to look at yourself. And this recent paper by Aragao and colleagues has some great images that show the enhancement and also some possible intrinsic T1 hyperintensity within the olfactory bulbs in these COVID-positive patients. I looked through our own cases and not of COVID, but just of different suspected viral anosmias. And here's just the one I could find that maybe there's a little bit of asymmetry and intrinsic T1 hyperintensity within the olfactory bulb, but it's kind of hard to tell on the post-contrast images. And furthermore, like I said before, this is a really tough area to image because you can have kind of failed or inhomogeneous fat suppression, which kind of can lead to like these kind of funny, shiny corners. So you gotta be really careful with your technique and try not to overcall things. Also be aware that there are some normal mimics of olfactory bulb enhancement. So this is a very common fake out. It looks like the olfactory bulbs are in fact enhancing, but this is actually someone who's completely asymptomatic and has no olfactory disturbance. And turns out this is actually a recently described venous pathway that we can actually see in most patients very easily. And it kind of runs from the nasal vestibule along the dorsal nose all the way to the olfactory recesses. Sometimes it's kind of like paired appearance is accentuated by dropping out a signal on the septum. But this is actually has nothing to do with the olfactory bulbs themselves. And they can be quite striking sometimes, and I've been faked out multiple times in patients who are being worked up for anosmia. I do want to talk about just the primary tumor of the olfactory epithelium, esthesioneuroblastoma. Most of you are already aware of it. It can be a very aggressive transspatial mass that invades through the cribriform plate. And the classic appearance is these enhancing peritumoral cysts along the superior margin. There is a scoring criteria for these tumors. You can see here in this hypercellular restricting transspatial mass, we have invasion from the paranasal sinuses through the cribriform plate, so therefore KH3. And these need to be distinguished from other sinonasal carcinomas, which can have a very similar appearance and signal intensity, and also lymphoproliferative disorders, which can also have a very similar MR signal and appearance. But just note that both of these are missing the superior peritumoral cysts. The effects of the cribriform plate can also be associated with anosmias, and particularly in the case of intracranial hypertension, that's been associated with decreased olfaction ability. And this is a patient who came in with the classic symptoms of idiopathic intracranial hypertension, but also had CSF rhinorrhea. And you can see there's the dehiscence of the cribriform plate with expansion of the fossae and the pituitary sella. Bring me to kind of central causes of dysosmia, and these can be really tough to kind of nail down clinically because it is a common feature of aging, but also a lot of neurodegenerative and neurocognitive disorders are associated with decreased olfaction. Also, sometimes patients are actually able to detect the smell. They actually will have like an intact olfactory organ, but cortically they're not able to process that, and so they actually have this like olfactory agnosia. So they'll smell something, but they can't quite name it or distinguish two different smells. And a lot of these patients might actually have kind of like vague or contextual odor complaints. So they won't be like smells like rubber. They'll say smells kind of like, I don't know, my basement, or smells kind of like musty. They'll have trouble actually naming the smell. These can be kind of vague complaints, and again, like very kind of difficult to nail down. But just keep in mind that if you have a patient with a known CNS disease, that this can actually be a very common feature of that. And showing that with age, there can be some decreased signal and size of the olfactory bulbs, but I find this prospectively very difficult to use. Here's an example of Alzheimer's disease, a patient with hyposmia and dementia. You can see there is atrophy, preferentially affecting the mesial temporal lobes with dilatation of the temporal horns. And this is a PET study using F18 radiolabeled fluorobetapir, which is a beta amyloid binding agent. And you see we have abnormal increased expression in the frontal temporal cortical regions, as opposed to this control, where it's more distributed in the kind of central white matter regions. Here's an example of a patient with multiple sclerosis. I wouldn't normally call this, but this patient did actually have hyposmia, and elsewhere in their brain did have an acute flare of their demyelinating disease. And these olfactory bulbs did appear somewhat overly bright and thickened. And you can use like the 1 year comparison to kind of see the change in time. So very difficult to, I think, prospectively call, but potentially real. More obvious case, neurosarcoid can do anything, and it certainly can cause infiltration and enhancement of the olfactory tracts, as well as the adjacent cortices. And this is a patient who came in with dysosmia and also had various other symptoms due to their lithomeningeal disease. And of course, we all know that trauma, usually through shearing, forces can disrupt the olfactory bulbs and tracts. And so here's a patient who actually didn't have a history of trauma, but had a sudden onset headache during a heated argument, and for several weeks afterwards kept smelling kind of like methane or kind of that sulfurous gas smell in his house. And eventually he got a scan when it was determined that he didn't have a gas leak in his house, and he had all this hemorrhage that was kind of tracking along his orbital frontal cortices and the cribriform plate. And of course, masses in along those olfactory grooves can cause hyposmia or dysosmia. And here's a case I had when I was a fellow. This patient had a giant aneurysm coming off of the ACA territory, causing compression of those olfactory grooves and tracts. I actually went to his hospital room, and I actually had him smell, with his eyes closed, a peanut butter cup and an orange, and he's like, yeah, I can smell something, it's familiar, I just can't tell you what it is. And so, maybe not the most controlled study, but I thought it was kind of interesting that, he did have potentially an olfactory deficit. And of course, epilepsy, as we all know, can present with olfactory aura. And so here's a couple patients who have mesotemporal sclerosis, who also had olfactory aura. And just an example of just another thing to be aware of. This is a different patient with hypometabolism corresponding to the right temporal lobe. And of course, gliomas and other masses, primary or metastatic, to go to the temporal lobe, can be associated with olfactory hallucinations. And it's turned out to be a GBM with intralesional hemorrhage. Okay, lastly, I want to talk about congenital olfactory disorders. Very complex topic, and it's kind of hard to, I think, get to kind of name these prospectively, because there's a lot of complex mechanisms at play here. The face and nasal cavity are developing at the same time as the kind of anterior neural tube, and so you can actually have a lot of sort of shared or multifocal malformations that can make these studies look a lot more complex. I would say if you have like a really isolated anomaly of the olfactory tracts, it's probably more related to like a transient insult at a specific time during development. Kind of more regional disorders tend to occur through disruption of kind of local signaling pathways, like the morphogen signaling pathways. And kind of more widespread global anomalies are potentially related to either a really upstream regulator of genetic expression or more kind of environmental type insults. So olfactory nerve development can be kind of complex, but in general, the olfactory pathways are developing alongside the rest of the prosencephalon. You have the kind of midline induction centers. So dorsally you have bone morphogenic protein, WNT. Kind of rostrally you have fibroblast growth factor, and then eventually you have sonic hedgehog. And these are stimulating the adjacent areas of the neurotube to develop in a certain way, but also sending information rostrally to the face and nasal cavity to develop the nasal pits and olfactory epithelium alongside the other kind of paramedian kind of signaling factors. It's pretty complex, but the general idea is that these structures all develop together, and so with congenital anomalies, you can encounter both kind of sensorineural and kind of facial malformations. here's a very striking case of that being true. So here is a case of congenital arrhythmia. It's this complete absence of the nasal structures and nasal cavity. And here you can see that the olfactory fossae are shallow and underdeveloped, and there's just kind of osseous fusion of what would normally be the cribriform plate. And along with that, there was no development of the olfactory tracts. Here's an example of another kind of midline induction failure. So we have semi-lobar holoprosencephaly, and the overlying face is notable for absence of the nasal cavity. So again, there's congenital arrhythmia. We have a central median cleft, and the olfactory bulbs and tracts are not present. Here's an example of more kind of regional induction failure. So when you see one absent cranial nerve in general, you should be looking at all the other cranial nerves. This patient obviously is missing their optic pathways, their globes are absent. And if you look at the olfactory fossae, you do have a hypoplastic left olfactory bulb and an absent right olfactory bulb. This is actually just a small vein that's causing a fake out. So a lot of these structures develop at the same time and are the same influences. And so it's common to see these things associated with each other. And here's an example, however, of an isolated congenital anosmia. This patient came in, and the parents just happened to notice that she wasn't able to distinguish certain smells, like dog poop or brownies. And so they had her checked out, and it turns out that she was just born without olfactory bulbs. But then you have a known association with olfactory congenital anosmia and pituitary dysfunction. So namely, a lot of people think of Kallmann syndrome, which is technically congenital anosmia with hypogonadotropic hypogonadism, but you can get other types of pituitary dysfunction as well. So this patient with absence of the olfactory bulbs and grooves, and those are just the little veins there, also came in with a hypoplastic or hypertrophic pituitary gland and stalk in the setting of failure to thrive with low percentile for height and weight. And then, of course, other more kind of global types of malformative conditions can be associated with absence of olfactory bulbs. So in the case of charge, the CHD7 mutation is important for chromatin remodeling and can be expressed in a wide variety of organs. So this patient with classic colobomas, choanal atresia with kind of layering fluid, and inner ear malformations also has agenesis of the olfactory tracts. And CHD7 is actually expressed preferentially in the olfactory bulbs, so a mutation would theoretically selectively target development of these structures. And of course, other types of more general syndromes, such as trisomy 18, can be associated with complete or partial agenesis of the olfactory tracts in this patient who also has tetralogy of Fallot with a presumed embolic stroke, emphalocele, and cleft lip palate. Certain types of ciliopathies are also associated with olfactory tract agenesis, and so here's an example of Joubert Syndrome with the classic vermian hypoplasia and molar tooth malformation of the midbrain, who came in with absent olfactory tracts, or a, I guess, classic case of Bardet-Biedel Syndrome, which is another type of primary ciliopathy where they essentially don't develop the normal sensory cilia along the apical poles of these olfactory sensory nerves, and so they never really develop a normal olfactory pathway, and see how hypoplastic these tracts are. They also have other features including polydactyly and renal failure. And so, these conditions can be very complicated and hard to navigate. So, I just try to break them up based on, am I seeing something that's very isolated? Am I seeing something that's kind of regional or something that's kind of global? And then kind of just work from there. And of course, we can use sophisticated techniques to also, cross-reference some of these symptoms as well. So anyway, takeaway points here. Olfaction is a very important and sometimes unrecognized aspect of human life. We can break them down into conductive, transductive, and central dysosmias. And a lot of times the conductive anosmias will be associated with other sinonasal symptoms, in addition to reduced olfaction, hyposmia, or anosmia. But the phantosmias and parosmias are more associated with a sensorineural type of olfaction disorder. And that central olfactory disorders may be difficult to characterize, but may accompany other CNS complaints and may herald the onset of other important neurocognitive and neuropsychiatric disorders. And knowing that these CT and MRI are complementary studies, but should always be preceded by careful patient interview and clinical exam. So thank you very much for your attention, and have a great rest of your meeting.
Our next lecture will be given by Dr. Asim Chowdhury, Associate Chair, Research Affairs, Department of Radiology, Professor of Radiology, Ophthalmology, and Neurosurgery at the University of Tennessee Health Science Center, and Chief of Neuroradiology at Le Bonaire Neuroscience Institute, Le Bonaire Children's Hospital, Memphis, Tennessee. His topic will be trigeminal neuralgia and neuropathy.
Hello. Today I'm going to talk about imaging of the trigeminal nerve, in particular as it relates to the imaging workup of trigeminal neuralgia. The goals are to review the imaging anatomy of the trigeminal nerve and its major branches, as well as relevant skull base anatomy. We will review the imaging appearance of select pathologic entities impacting the trigeminal nerve. And ultimately, I'd like to understand the clinical presentation of patients with trigeminal neuropathies, the associated terminology used by clinicians, and available treatments. Regarding anatomy of the trigeminal nerve, there's numerous nuclei in the brainstem. There are sensory fibers, controlling pain and temperature sensation, as well as touch and position sensation from the face. There are motor fibers, which control the muscles of mastication, as well as the tensor tympani, tensor villi palatini, the mylohyoid, and the anterior belly of the digastric. The Blitz segmentation model is very helpful for thinking about cranial nerves. There's a nucleus within the brainstem, there's an intraaxial fascicular segment, a cisternal segment, a dural cave segment, an interdural segment surrounded by venous blood, a foraminal, and an extraforaminal segment. This is relevant because abnormalities anywhere along this pathway can result in abnormalities of a given cranial nerve. The trigeminal nerve, we most commonly think of the cisternal segment as the easiest to identify and a great place to start. This is what it looks like on an axial image. And on a coronal image, we can see the cisternal segment of the trigeminal nerve coursing inframedial to the free edge of the tentorium along the lateral aspect of the brainstem. Revisiting this axial image, there are several other landmarks that we can see. There is the cisternal segment. Anterior to that is Meckel's cave, the dural cave for the trigeminal nerve. And the interface is the porus trigeminus, that is the dural opening. And also relevant is the root exit zone, which is where the apparent origin of the fibers coming from the brainstem to the cisternal segment is. If we look on this coronal T2 weighted image, we can see Meckel's cave here. This is the home of the Gasserian ganglion, the ganglion of the trigeminal nerve. Anterior to that is the cavernous sinus. Along the lateral margin of the cavernous sinus, you can see multiple cranial nerves, 3, 4. And then below that, you can see branches of the trigeminal nerve, the V1 segment or ophthalmic segment, and the V2 or maxillary segment. Within the cavernous sinus is the abducens nerve, the only nerve traveling within the cavernous sinus. Now, note that the V3 or mandibular segment of the trigeminal nerve does not travel within or alongside the cavernous sinus. Here's another view of the cavernous sinus on a cartoon drawing showing the branches, in particular the V1 and the V2 branches, and then a coronal post-contrast cis image showing those same findings. From there, it goes to the foraminal segments. And from Meckel's cave, we can have the V1 segment here going through the superior ophthalmic fissure, the V2 segment going through foramen rotundum, and the inferiorly directed V3 segment going through foramen ovale. Those three main branches, the ophthalmic, the maxillary, and the mandibular branches, have dermatomal distributions of the face, which are relevant to know because that may impact which segment you are worried about looking for pathology if there are symptoms related to a given distribution. On CT, it's relevant to be able to see the superior orbital fissure, which carries the V1 segment connecting the middle cranial fossa to the orbital apex. Inferiorly, you have foramen rotundum, which carries the V2 segment as it traverses from the middle cranial fossa to the pterygopalatine fossa. Inferiorly, we see foramen ovale, which carries the V3 segment as it connects the middle cranial fossa to the infratemporal fossa. On a coronal view, we can see the superior orbital fissure again. It carries several cranial nerves, cranial nerve 3, 4, 6, as well as relevant to this topic, the V1 segment, connecting the middle cranial fossa to the orbital apex. Inferior to that, we see foramen rotundum carrying V2 from the middle cranial fossa to the pterygopalatine fossa. This coronal view through the mid-orbits, we can see the infraorbital canal. The infraorbital canal carries a V2 branch called the infraorbital nerve. This is relevant for post-traumatic imaging as well. On the sagittal view, you can see foramen rotundum as it carries the V2 segment connecting the middle cranial fossa to the pterygopalatine fossa. Anterior to that is the pterygopalatine fossa. Now, we can sometimes see the extraforaminal segments if we're very careful in our image acquisition and interpretation. So on this coronal cyst view here, we're going to have the arrows follow the V2 segment as it goes along the cavernous sinus, anteriorly as it goes through foramen rotundum. Here it's going through foramen rotundum into the pterygopalatine fossa. It's continuing to course anteriorly. Now it's going inferior to the orbit. In the infraorbital canal is the infraorbital nerve. We can also see the extraforaminal segment of the V3 segment here, where we follow the lingual nerve from foramen ovale to the mandibular foramen. Here are some case examples involving the fifth cranial nerve. It is relevant to talk about the technique of post-contrast CIS or Fiesta imaging. It's a high-resolution fluid-sensitive technique relatively resistant to CSF pulsations. It's commonly referred to as a variant of a T2-weighted sequence, but that doesn't tell the full story. It has T1 properties as well, so contrast can be useful. In particular, for evaluating the interdural segments surrounded by venous blood. So we can see this parasagittal view of the abducens nerve coursing. We can see the dural interface and then the interdural segment, and we can see the abducens nerve coursing through the cavernous sinus towards the orbital apex. So this is a way of using post-contrast CIS imaging to your benefit when looking at the interdural segment of the cranial nerves. This patient presented with multiple cranial neuropathies. We see a mass in the left cerebral-pontine angle cistern, and if we look at post-contrast CIS, we can see that CIS is more than just a, quote, heavily T2-weighted image. This mass enhances. Now, we don't know where it's arising from. We don't know if it's arising from a cranial nerve or just impacting the cranial nerves. This is when it's relevant to think about the actual microstructural anatomy of the cranial nerves. So in particular, the cisternal segment we're going to look at, because that would be potentially where this lesion would arise if it was arising from a cranial nerve. And so we'll think about the central nervous to peripheral nervous system transition. The central nervous system is myelinated by oligodendrocytes. The peripheral nervous system is myelinated by Schwann cells. And in between is the central nervous to peripheral nervous system transition zone. Now, that transition zone actually takes place a few millimeters distal to its apparent origin from the brainstem. Now, for the eighth nerve, which is relevant to the cerebral ponting angle cistern lesion shown, that transition zone takes place far off from the brainstem. That's one of the reasons why you can be sure that this is not a vestibular schwannoma, and why a vestibular schwannoma will always occur within this internal auditory canal. Now, that transition zone is also known as the Obersteiner-Redlich zone. And given that the proximal cisternal segment of the cranial nerve is myelinated by oligodendrocytes, there's no Schwann cells, so therefore no schwannoma. And here's this coronal view showing this actually is a meningioma arising from the tentorium. And on an axial cis up at the level of the cisternal segment of the trigeminal nerve and from Meckel's cave, we can actually see the cisternal segment of the trigeminal nerve draped over the anterior margin. And this was helpful for the surgeon to be able to know where to expect it to allow nerve preservation during resection. You can also appreciate the inferior deflection of the cranial nerve 7, cranial nerve 8 complex. So this patient actually, we don't see a cisternal segment of the trigeminal nerve on the left side. We see an empty left side Meckel's cave, and we also see atrophy of the left-sided muscles of mastication. Here's a patient with what's called Gomez-Lopez-Hernandez syndrome. It's a triad of rhombencephalosynapsis, alopecia, and anesthesia in the trigeminal nerve distribution. And interestingly, we noted that there was no cisternal segment of the fifth nerve seen on this patient. On CT scan, we noticed that there was actually no foramina rotunda as well. So just another interesting observation linking the anatomy of the trigeminal nerve itself and its association with skull-based foramina. This patient presenting with new onset seizures is noted to have edema in the medial aspect of the left temporal lobe. Coronal imaging confirms the edema, and note the relationship to Meckel's cave. This is HSV encephalitis, and people often say HSV encephalitis involves the temporal lobe, which is true, but that doesn't tell the full story. HSV encephalitis is often related to orofacial HSV activation in the Caesarean ganglion, which therefore results in preferential involvement of the mesial temporal structures that are adjacent to Meckel's cave, as seen here. This is a patient with a V3 segment nerve sheath tumor that we can see extending inferiorly from foramina valley. This is a patient with neurofibromatosis type 1, and we see a large plexiform neurofibroma involving the face, and there's significant enlargement of the left foramina valley. There's also mass-like enlargement of the left cavernous sinus with high-grade compression of the intracranial portion of the left internal carotid artery, and extensive facial involvement of this plexiform neurofibroma. Here's a patient with right-sided facial pain that was found to have a maxillary sinus mass. That maxillary sinus mass eroded through the posterior margin of the maxillary sinus into the pterygopalatine fossa. Here's the MRI showing the heterogeneous enhancing lesion. And one thing to be aware of for these lesions where soft tissue characterization is best oftentimes on MR and bony characterization is best sometimes on CT. Sometimes fusing the CT and the MR is something that can help, especially the surgeons and oncologists and even the patient understand better what's going on. So now to talk about trigeminal neuralgia. This is a chronic pain condition mediated by the trigeminal nerve. Is potentially very debilitating. It's also known as tic douloureux. It's often idiopathic, however, it can be associated with nerve compression and neoplastic involvement. The symptoms can be episodic with sudden, severe pain lasting a few seconds to a few minutes. It can be a low-grade constant pain, and for some individuals, it can be a combination of low-grade constant pain with superimposed burst of more severe pain. It's most commonly seen in patients over 50 years of age, but it can be seen at any age. In younger patients, it's often a manifestation of multiple sclerosis. It is more common in women, and the incidence is approximately 12 cases per year per 100,000 individuals. So in most cities, this will definitely be encountered from time to time. Diagnosis is aided by a good history, including evaluation of the character of the pain and other associated factors. Workup often involves evaluation for treatable factors such as history of shingles with associated post-herpetic neuralgia. Imaging is an important part of the evaluation of trigeminal neuralgia to look for masses or possibly neurovascular compression. Typically an MRI, often an MR angiogram as well. Neurovascular compression is a key thing to be aware of because it is the most common identifiable cause of trigeminal neuralgia. It is compression of the root exosome of the trigeminal nerve by either the superior cerebellar artery or the anterior inferior cerebellar artery. It may involve focal contact, mild mass effect, or significant displacement of the nerve fibers. And a grading system that's sometimes used in research studies that may not be something you put in your report, but to be aware of this gradation is important. Grade 0 is no contact. Grade 1 would be simple contact without displacement or distortion of the nerve. Grade 2 is displacement and or mild distortion. Grade 3, severe distortion or change and decrease in the cross-sectional area of the nerve. So as you can see, those are the concepts that go along with more severe neurovascular compression. Here's an image showing this vessel causing a focal contour irregularity in the proximal cisternal segment of the right trigeminal nerve. That is one of the things that you sometimes will see, and seeing this makes the diagnosis a little bit easier. What is the treatment? There's pharmacologic methods, anticonvulsant agents, there's tricyclic agents, and there's several surgical or interventional options. There's ablation, whether chemical ablation, thermal ablation, and there's radiosurgery, and microvascular decompression. And the choice of which of these to perform is a lot of times guided by imaging. So we have a role to be able to help to see whether or not certain surgeries, in particular microvascular decompression, may be worthwhile. What is microvascular decompression? It is performed when the trigeminal nerve is felt to be related to irritation from vascular pulsations, and a physical barrier, such as a small piece of Teflon, is placed between the nerve and the blood vessel. We have already seen several examples where contrast-enhanced cysts can aid in characterization of a lesion. On this image, with the patient with right-sided trigeminal neuralgia, on the coronal image, we see a thickened right cisternal segment of the right trigeminal nerve. But post-contrast, we can see that part of this is actually a vessel. It turns out to be a vein that is causing mass effect upon and flattening of the infralateral surface of the cisternal segment of the right trigeminal nerve. And so contrast-enhanced cysts can definitely be very helpful. It's worthy to note that neurovascular contact of the cisternal segment of the fifth nerve is not uncommon in asymptomatic individuals, potentially up to 88% in some series. And some patients with trigeminal neuralgia have no neurovascular contact. And not all patients with neurovascular contact respond to microvascular decompression. What does that mean? it means we really need, both on an imaging standpoint, neurology, neurosurgery, to do whatever we can to find candidates who have an optimal result from microvascular decompression. And this is where I think recent information has shown that contrast-enhanced cysts may be able to help contribute to that. So in this recent paper, if we look at what they call type 1 pain relief, which means that postoperatively you have complete pain relief without need for medication. That's the goal. So in these patients, the grading of the neurovascular contact was higher with post-contrast cysts. And those ones with higher grades ended up doing better. So patients with little or no neurovascular compromise were less likely to experience pain relief compared to patients with a high-grade neurovascular compression. And 58% of the high-grade neurovascular compression in this series was actually related to venous compression. So those are important things to be aware of. And the post-contrast cysts can really help with that in a way sometimes even that MR angiogram doesn't, if your MR angiogram is not set up on a post-contrast basis to look for veins. Where's the location of the neurovascular compression? Well, most of the higher grade neurovascular compression, which are the highly symptomatic ones that respond to neurovascular decompression, microvascular decompression, take place between 3 to 6 millimeters from the surface of the pons. So the proposed pathophysiologic mechanism of vascular compression is microstructural irritation and injury to the nerve at the transition zone between the central, peripheral, and peripheral myelin, or the Obersteiner-Redlich zone that we discussed earlier. And that irritation may make the axons hyperexcitable, giving rise to pain. So what are some takeaway points about microvascular decompression? The presence and severity of trigeminal nerve root compression has been shown intraoperatively and by imaging to be predictive of favorable outcomes after microvascular decompression. The degree of compression of the root, rather than simply whether or not there is contact, is most predictive of symptoms of trigeminal neuralgia and most predictive of favorable outcomes after microvascular decompression. One other thing to be aware of when doing an imaging workup, especially since you can have incidental neurovascular contact that may or may not be related to trigeminal neuralgia, is if there is pain and also loss of sensation, that's when you really need to think of a mass or perineural spread of tumor as the cause of trigeminal neuralgia. So just because you may see low-grade neurovascular contact ipsilateral to the symptoms, that may not be the cause. So you need to always be on the lookout for other possible causes. I want to talk for a moment about snow cones and the resultant brain freeze. So brain freeze is also sometimes known as sphenopalatine ganglioneuralgia, and it's irritation of nerves in the palate, which are distal V2 branches, due to the cold temperature. And resolution of symptoms can be accelerated by warming the palate with your tongue, or you just wait it out. But it's generally very uncomfortable. Anyone who's experienced it knows it's fairly uncomfortable, and if snow cones and ice cream wasn't so good, we would probably avoid them. But as uncomfortable as it is, think that's what some of these patients are dealing with on a daily basis. And we have the opportunity with high-quality imaging and a consultative relationship with the neurologists and neurosurgeons to hopefully try and help these patients. So these patients are dealing with brain freeze, that type of pain, almost constantly. So this is why understanding some of these points can definitely have a significant clinical impact. So advanced visualization, we sometimes use 3D visualization for surgical planning, as well as it's especially helpful for education, whether of trainees or of patients and their families. We've also done 3D printing of cranial nerves. So we'll take high-resolution imaging, CT for bones and MR for nerves and soft tissue, and do segmentation, typically an automated segmentation with manual confirmation. And that will result in these computerized models of the brainstem and cranial nerves. And then that computerized model can be printed with a 3D printer. And we can take this brainstem and cranial nerves that's printed from the MRI and take a 3D printing of the skull that was made from a CAT scan and put those together. Here's the virtual image. Then this is a 3D print showing, we can see the cisternal segment of the trigeminal nerve, the Gasserian ganglion. We see the V1 segment going through the supraorbital fissure, joining up the third and fourth nerves and the sixth nerve. We see the V2 segment going through foramen rotundum, and we see the inferior displacement or inferior direction of the V3 segment going through foramen ovale. A few take-home points. Trigeminal neuralgia is a debilitating chronic pain disorder. Trigeminal neuralgia is often caused by neurovascular compression. Imaging analysis can aid in identifying patients with trigeminal neuralgia who may best respond to microvascular decompression, in particular those with high-grade contact and deformation of the nerve. Contrast-enhanced cysts can improve the ability to detect that high-grade neurovascular compression, which is a predictive factor to symptom relief after microvascular decompression. And it's always important to remember, incidental detection of neurovascular contact on a study that is not performed for trigeminal neuralgia is typically of no clinical consequence. Here's some suggested readings if you want to learn more about high-resolution imaging as well as the imaging of trigeminal neuralgia. I would like to thank the program committee of ASHNR2020 for inviting me to speak. I want to thank Ari Blitz. He's my colleague and mentor on high-resolution and skill-based imaging, and he's collaborated with me on several of these topics. And also Dr. Ramin Javan, who has worked with me for a number of years on 3D printing. Thank you very much.
Our next speaker is Dr. Jeffrey Gwinnett, Assistant Professor of Radiology, Brigham and Women's Hospital, Dana-Farber Cancer Institute, Harvard Medical School, Boston, Massachusetts. His topic will be facial weakness.
Thank you to Dr. Schmalfuss and the ASHNR for inviting me to present on facial weakness this year. My name is Jeff Gwinnett, and I'm a neuroradiologist at Brigham and Women's Hospital and Dana-Farber Cancer Institute. I have no disclosures. There are three primary categories of learning outcome for this talk. The first is knowledge, where we go through the anatomy of facial muscle innervation, causes of facial weakness, and imaging options and methods when the indication for an exam is facial weakness. The primary skill I want people to walk away with is how to perform proper imaging examinations for facial weakness. And then the main value I want you to take away is that knowledge of anatomy is essential for developing imaging protocols and knowing where to look for any exam, but in particular in this case for identifying causes of facial weakness. There are two primary takeaway points from this lecture. The first is that the differential pathophysiology and anatomy guide where to look in the case of facial weakness. We want to make sure we're looking at the whole brain, the skull base, especially in the temporal bones, and the parotid gland and face along the entire course of the facial nerve. And also, to that extent, the second takeaway is you have to image the entire course of the facial nerve, and this causes some issues in that generally there's overlapping exam codes and orderables and billables, and how do you decide to perform the correct exam? How do you set up your protocols? And we'll get into that a bit later. First, we'll go through the anatomy of facial muscle innervation. So we'll start, so just to be clear to start, we're talking about cranial nerve 7 and the muscles of facial expression. We're not talking about the orbit muscles, which are cranial nerves 2, which are cranial nerves 3, 4, and 6. We're not talking about the muscles of mastication, which are cranial nerve 5. We're talking about a facial nerve palsy and facial weakness being a weakness in the muscles of facial expression. So cranial nerve 7. Now, the generally taught facial nerve anatomy has 5 primary branches. You get a main trunk that comes out of the stylomastoid foramen into the parotid gland. You get 5 branches, which many people remember with the mnemonic 2 Zanzibar bimotor car, the temporal, the zygomatic, the buccal, the marginal mandibular, and the cervical branches. Now, this is a bit too simple for our purposes when we think about high-resolution imaging of the facial nerves, especially the extracranial facial nerve and where those branches go and how to image them. The more realistic facial nerve anatomy looks a bit more like this. You have a facial nerve trunk that comes out of the stylomastoid foramen, and then it bifurcates. And it bifurcates typically within the parotid gland. The top bifurcation is called the temporofacial trunk, and the bottom bifurcation is called the cervicofacial trunk. Those two trunks then separate into lots of different nerve fibers, which are called the parotid plexus. These nerve fibers are below the resolution of current imaging, and so once we get past that bifurcation and down the temporofacial and cervicofacial trunks a ways, the nerve becomes unable to be imaged by us at this time. So we then lose it, regardless of the resolution of the imaging or the type of imaging that we're doing. And we see this repeatedly in all of the studies that have been performed using different sequences in MRI to date. That parotid plexus then rejoins, those nerve fibers from the parotid plexus rejoin into what's generally regarded as the 5 classic branches of the facial nerve. However, it's very important to note that the branches are often variable and present in duplicate or triplicate. So the distal branches also, the way we would image them, first of all, they tend to be too small to image, but second of all, they don't follow the classic specific 5 branches that we think of. It is also possible to image the facial nerve through the temporal bone in MRI using an ultra-short TE sequence. And here you can see the cisternal segment going to the labyrinthine segment in the genu, then coming back along the tympanic segment through the temporal bone, and then down the descending portion through the mastoid portion, called either the descending or mastoid portion, down to the stylomastoid foramen. We typically don't use the sequence, although it is interesting to be able to see the facial nerve through the temporal bone. Typically, if we're looking for specific facial nerve anatomy in the temporal bone CT would suffice. So moving backwards even further, once we get back into the brainstem, into the nucleus of the facial nerve, or the nuclei of the facial nerve, the facial nucleus is the nucleus that has the motor component of the facial nerve and innervates the muscles of facial expression. And that nucleus, remember that in anatomy images, the images tend to be inverted, so anterior is at the bottom of the screen here and posterior is at the top. And so the facial nerve nuclei are located in the mid to lateral portions of the posterior aspect of the pons inferiorly. Here we see a section, a histologic section, that also shows the facial motor nucleus highlighted in purple, again in a similar location. And one thing to know about the facial nerve nuclei, and this is important in the clinical practice for determining whether a facial paralysis may be central or peripheral, and it's that the upper motor neurons for the upper face project to the bilateral facial nerve nuclei. So what that means is that if you have an upper motor neuron lesion, something above the pons, and you have facial weakness as a result, you're going to have sparing of the forehead, because those forehead fibers are innervated by both sides, or those forehead fibers go to both facial motor nuclei. So upper motor neuron lesions spare the forehead classically. Going up to the upper motor neurons, here's a picture of the homunculus, and just to remind ourselves that the region of the face on the motor strip is in the lateral aspect of the precentral gyrus. And here you see that indicated with a functional MRI where you see motor activation from the face, from a lip pursing task, where you see this activation in the lateral aspects of the motor strip in the frontal lobes. Next, we'll talk about causes of facial weakness. There are a lot of causes of facial weakness. Herpes simplex reactivation is thought to be the cause for Bell's palsy. It's not proven, but that's the classic. Bell's palsy is the classic facial nerve weakness, and it tends to be a rapid onset over hours to a couple days. It then progresses a little more slowly over a week or two, and then it starts to improve over time. And most people have substantial improvement over the first few months. Herpes zoster can look the same on imaging and has this very similar presentation. Lyme disease and HIV are much less common, but there are reported cases. Otitis media can cause facial weakness due to inflammation along the facial nerve in the temporal bone. Guillain-Barré would be unusual to have an isolated facial nerve weakness, similar for sarcoid and Sjogren. Tumor is a classic cause of facial weakness that we encounter in our practice all the time. You can have tumor anywhere along the course of the innervation of the face. Often we see tumors in the parotid gland, but you can have lesions you can have tumors in the temporal bone and the IAC that can also cause facial weakness. And ischemic and hemorrhagic stroke can also be a cause of facial weakness. Typically, if you have an upper motor neuron cerebral lesion in an infarct, it's going to involve more than just the facial nerve. However, you can have very small lesions that would involve just the facial, or that would involve just the muscles of facial expression. We'll show some cases on these later. So when is imaging indicated? Generally, we aren't going to be determining this, but essentially, if you have a classic Bell's palsy in clinic, it doesn't need imaging. However, if there's any atypical physical sign or presentation, forehead sparing, a facial twitch or spasm preceding the paralysis, or slow onset, then imaging is certainly indicated. We're concerned for a central motor lesion or a tumor. If there's slow progression of paralysis on beyond 3 weeks, often that is because of tumor as opposed to a viral type illness or an autoimmune illness. And if there's no improvement at 4 months, we also have a high suspicion. So I do see that we're imaging for facial paralysis early more frequently. I think that's due to liability concerns on the primary providers or more patients coming into the emergency department for this, where they want to clear them from anything life-threatening. So we will see some acute facial nerve paralysis imaging, and the findings on that are somewhat different than the more later presentations. So imaging options and methods for facial nerve weakness. So which protocol to use when imaging for an indication of facial weakness? As I discussed earlier, you have to image the whole brain through the whole face, essentially, the whole course of innervation of the facial muscles. So a routine brain is great for infarct or tumor centrally, but it's not going to have high-resolution imaging of the skull base or temporal bone in most cases, and certainly not imaging of the face. An MS protocol of the brain will have similar issues, although many MS protocols do have higher resolution imaging through the whole brain that covers the skull base, but again, typically not going to include the face, and really only appropriate if the person has known demyelinating disease and you're considering a new lesion. So skull base and temporal bone protocols are typically what are used by providers when you're concerned for Bell's palsy, because you're looking for inflammation in the fundus of the IAC. However, again, you tend to miss face imaging, so you would miss a parotid tumor. We have cranial nerve protocols at our institutions, which are tailored to include high-resolution imaging of the skull base with either a T2 space or a KISS sequence, as well as 1 millimeter thin post-contrast images through the skull base, as well as screening images of the brain, including a FLAIR and a T2 FLAIR and a DWI, and as well as screening images of the face, typically of at least pre-contrast T1 weighted imaging. So then we get the whole course of the cranial nerves. A parotid tumor or other face protocol is, also less ideal unless you include some type of screening brain imaging. Generally, a DWI and a FLAIR would be sufficient, post-contrast plus or minus, depending on how your practice runs. So we'll talk very briefly about some advanced facial nerve imaging protocols. Here you see a PSIF-DWI, a PSIF-DWI imaging sequence, which has been used and is being published upon frequently for neurography throughout the body. This study used a surface coil, and they were only able to image to the bifurcation. As we described earlier, that's what would be expected when you truly understand the facial nerve anatomy. but it does involve specific equipment, and also whether we're going to see pathology or not along the course of the facial nerve is not determined at this time. The study and most studies looking at these advanced imaging have been in healthy volunteers to see if we can even see the nerve. Diffusion tensor imaging has also been published. In general, this has been published looking at tumors, and you can see the course of the facial nerve along the tumor for surgical planning. It involves a lot of post-processing, and again, how DTI would explain or would identify any type of pathology of the facial nerve itself is very unclear at this point. We have done some DTI of the extracranial facial nerve at our institution with very mixed success, involving a lot of people doing post-processing in various ways. So it's a very time-intensive technique. We've been using a SSFP sequence, a KISS on Siemens scanners, and we can see the facial nerve pretty consistently down to the bifurcation and past the bifurcation to the parotid plexus on pretty much all studies. This is included standard in our parotid tumor protocol. It's not included in our cranial nerve protocols as a screener. This is really for surgical planning. I'm not sure if you would be able to see any kind of inflammation in the nerve on this, and I actually doubt it. These are sagittal reformats of the nerve, so you can see the nerve exiting the stylomastoid foramen and coming down to the bifurcation and past the bifurcation, where you see the full extent of the trunks of the craniocervical trunk and the temporofacial trunk and the cervicofacial trunk. So here are some cases to go through what we've been talking about. So here you see a large mass in the right parotid gland. This is a patient in the 60s with prostate cancer, 7 months of right facial nerve weakness. It had been treated as a Bell's palsy, but it had progressed and it had not resolved at all. And in this exam you see there's this large infiltrating mass throughout the parotid gland. And then on the right side, to the point of imaging further up in the head, here you see tumor with the red arrows along the geniculate and labyrinthine segments of the intracranial facial nerve, and then slightly more anteriorly you see there's tumor along V3 as well. So there's perineural tumor spread in this case. A similar case here in the left parotid gland. It's an 83-year-old woman, very similar story, treated as a Bell's palsy, failed to improve over time. This imaging was finally performed at 10 months with persistent left facial nerve weakness, and you see this large tumor, and this was a basal cell carcinoma metastasis. The last case was a squamous cell carcinoma metastasis from an unknown primary. There was no identified squamous cell carcinoma skin primary in the head. This is the same woman with the basal cell carcinoma. This is the KISS sequence or SSFP sequence, both on the left in the axial plane and on a sagittal reformatted plane on the right. The red arrows point to the facial nerve, which you can see is very expanded as you enter the tumor, and this tumor was resected, and along with the facial nerve, and the pathology demonstrated gross infiltration of the facial nerve by tumor. So I do think this KISS sequence is able to show us when the facial nerve is grossly invaded by tumor, though we haven't had many cases to definitively claim that. So this is a young woman with Bell's palsy. She had with a history of Bell's palsy 20 years ago, presenting with a new facial droop. Once someone has a history of Bell's palsy, there is a higher incidence of having Bell's palsy again in the future. So whether this is a herpes simplex reactivation or not, we're not sure. But this does show the classic finding. We're on the fluid-weighted sequence. There's no abnormality in the internal auditory canal. But then here you see the red arrow pointing to some enhancement in the fundus of the IAC, and that's classic for Bell's palsy. This woman also had imaging 3 years later, and you can see that the enhancement was resolved at that time, as would be expected. Here's another young woman. This is a woman with AML, leukemia, on chemotherapy. She's immunosuppressed, and this is another time when you see an increased incidence of Bell's palsy. And this ended up being also a classic Bell's palsy. You see the similar finding here in the left IAC with the inflammatory enhancement in the fundus. Now here's a 41-year-old male with very similar findings, but in addition to the facial weakness, he also had sensorineural hearing loss, and on physical exam he had a rash in the external auditory canal. So although you can't tell a difference in imaging between Bell's palsy and Ramsay-Hunt syndrome, this is a classic Ramsay-Hunt syndrome with herpes zoster reactivation. And here we have a 70-year-old male with melanoma, and you see a much more nodular, more infiltrating appearance of the enhancement in the left internal auditory canal, as well as a mass in the fourth ventricle. These are melanoma metastases. Moving up more centrally, here's a lesion in the pons. This person actually did present with a right facial droop, so this ischemic infarct is hitting the facial nucleus on the left. Is hitting the facial nucleus, and the thing is, this person did present with a pronator drift, which makes sense given that you're seeing the infarct in the anterior aspect of the pons as well as more posteriorly. As we discussed earlier, remember that a lesion in the pons is not going to cause forehead sparing, even though it's a central lesion, because it's only going to hit one of the facial nerve nuclei if it's small enough. Now, this young woman did present with an isolated facial droop. It was transient. She does have a history of lupus. So this is a lupus-related ischemic event in the right corona radiata that happened to hit the facial region. And so similarly in multiple sclerosis, you could see an active demyelinating lesion in this area. These are the types of central lesions that could cause a forehead-sparing facial droop, where you're really truly only going to get one area. Most larger ischemic infarcts are going to have many more neurological symptoms. So thank you for spending the past 20 minutes with me. Again, I want to stress the key takeaway points, or two key takeaway points. Understanding the differential pathophysiology and anatomy are going to guide you where to look in the case of an indication of facial weakness, and it is critical that you image the entire course of the facial nerve. You have to image the entire brain and the face along all of the innervation pathway of the facial nerve to ensure you're going to find the pathology that's causing it. At our institution, we generally add on we have our protocol set up so that you can protocol a cranial nerve protocol from either a brain order or a face order, and we just image both with only one billable, either billing as a face or a brain. I hope this is helpful. Thank you again to everyone for inviting me for today.